The next would be, this is a follow-up ABG. So after she was ventilated, we got a follow-up ABG. So there are a few changes from the previous one. So here, the pH is better now. So pH has improved. Carbon dioxide has also, come down significantly. It's around 50. Oxygenation is good, around 71. And saturation is around 72. So with this picture, patient was actually obeying commands and she was good. And finally, the patient could be extubated. She didn't have any neurological defects. So these are all to give clues to us in the clinical. We cannot completely rely on this because we have to take all ABGs with a pinch of salt because sisters take ABGs. There could be some sampling errors. There could be some errors with the machine. So everything has to be interpreted with a grain of salt. But definitely the ABGs would be very handy, especially in low resource settings.
I think we will try to explain them in the workstation where we will give each one a ABG and try to explain them.
Okay, sir. Sure, sir.
We will move on to the next talk now.
Okay, sir. Sure. Thank you so much.
Thank you, Dr. Usha. Actually, if you see the last case, the patient is unconscious. If we just miss the ABG, so this patient will undergo many CT scans, MRIs, neurology consultations and all. So a simple ABG will give you an explanation why this patient is drowsy and what is the reason for the drowsiness. So with that, we'll go to our next session. The next session is case-based approach in endocrine emergencies. To go through that, we have Dr. S. Kaladar, who is a HOD Critical Care Medicine at Yashoda Hospital, Malakpet. Over to Dr. Kaladar.
Thank you, sir. So, good morning all. So, yeah. Endocrine emergencies. We'll go through this topic. I think day in and day out we'll be dealing, especially these patients who will come to the ICU. If they have any underlying endocrine emergency and if it's go undetected, then it poses a significant issue. That is the reason should be able to pick up those things. We do get these type of patients. I think Dr. Srinivas sir, recently we had one patient who presented with mixed edema, coma and all. So I will quickly rush through, especially metabolic functions of the body. So there is technical issue. Yeah. So anyone can tell what are the different endocrine emergencies one by one? Sir, please. Very good. DK, presenting with coma. Okay. Any other endocrine emergencies? Hypoglycemia, yes. It is also one of the endocrine emergencies. That's right. Any other thing? Yes, TSH has gone up. So that is what probably we see sometimes patient coming with even coma situation. But that's called mixed edema coma. That is hypothyroid crisis. Yeah, thyroid crisis. Yeah. Addison's, very good. I think most of you know what are the different endocrine emergencies. So that is what we will be dealing. These are the different endocrine emergencies that can be there. So I will begin with my case presentation. A 50-year-old male patient brought to here in a drowsy state. He has a background history of carcinoma, lung and chemotherapy, and definitely these underlying malignancies most of the times they will be cachectic. So these are the parameters on presentation. So he was having a heart rate of 140, blood pressure was fairly maintained, and his saturations were okay. So GR base found to have 42 milligram per deciliter. So what do you think? Do you think is it a significant hypoglycemia? Why so? Why so? So what are the different symptoms of hypoglycemia? Okay. But do you think, do you have to act upon this? Because it is 42.
Yes.
So why do you want to act upon? So that is where it boils down to different symptoms of hypoglycemia that we have to look at. So what do you think?
Hypoglycemia patient presents with palpitations, sweatings, abnormal behavior,
Very good.
and hunger. The most important.
Nice. Yeah, definitely. This patient, as we were telling the history, the patient presented with an drowsy state. So definitely it's a significant hypoglycemia. So what is neuroglycopenia? Sir.
Time, I think you have to target.
We have to, yeah. So, Whipple's triad. So, Whipple's triad is the one which we generally look at. If there is a symptomatic hypoglycemia, as we were discussing about different types of symptoms that can present hypoglycemia at the same time, there is a documented plasma glucose which is less than 50, 55, and it will be reversed after giving the, most of the time what we give is dextrose 25. So, this is how you define as Whipple's triad. So what do you think in this patient? What should be your first line of treatment? Do you straight away go for giving 25 dextrose, or do you want to give anything else before that? As the patient is carcinoma underlying and is cachectic, probably malnourished. Anything you want to give? Very good. So thiamine has to be given initially most of the times. So why so? Because the patients who are like maybe background alcoholics and maybe background cachectic patients who have thiamine depletion and thiamine deficiency, straight away if you give the glucose, the possibility of worsening underlying neuroglycopenia and sometimes landing up renal encephalopathy will be the problem. Because thiamine is involved in different glucose metabolism cycle, that is the reason it has to be given early. So then proceed with 25 dextrose. So we'll go for another case. A 60-year-old female presented to emergency room, obtended with a sick look and known diabetes, mellitus and hypertension, and with having fever of last 4 days. So as you look at this patient, is having a respiratory distress around 35 per minute, tachycardic 118, and BP on the lower side. Being hypertensive, we do expect these patients to be having a BP on the higher side. Saturations are okay. When you look at physical examination, should also be dehydrated. What do you think? What is the possible diagnosis at this juncture? Can anyone quickly tell? Grossly dehydrated, background diabetes. What do you think? Yes. So the possibility of decay, GRBS on the higher side. So this is how the ABG, as Usha was mentioning about what is acidosis and alkalosis and all. So if you look at, this is the ABG which is around 7.1, severe metabolic acidosis with an anion gap of 25. So this is how the patient can present severe decay sometimes. So the differences between decay and HSS are very important. Because as you look at asthmatic hyperglycemic state, they actually you have the sugar elevation is pretty much compared to decay, maybe sometimes above 1000. As the sugar can contribute significantly to hyperosmolarity of the blood, so the hyperosmolar state will be there, because of which the patient can be uptrended more as compared to decay patients. So this is how as you look at decay, it is more of keto acid production, where you look at when you look at ABG, the acidemia is more, the ketones are easily detected. So these are the different features that we have to look at. So that is how you differentiate. But HSS develops over a period of more time, like maybe sometimes weeks slowly, rather than decay, which can be very acute onset. So the crux of treatment, I think probably you might all be knowing how to approach. There are 2-3 principles that we have to target. One thing always, first and foremost, fluids. Next, give insulin. And the metabolic parameters, especially looking at potassium, sometimes phosphate. We had recently had one patient who is a 23-year-old detected diabetes, presented with severe dehydration, severe acidosis, and there was significant hypotension with requiring noradrenaline and vasopressin. So we looked at her phosphate, which was less than 0.5. Sometimes looking at phosphate, most of the times it is being ignored. So that can contribute to significant myocardial contractility until unless you sometimes replace the patient, hypertension may not improve. So these are the different parameters that you have to look at. And most of the times, decay will be associated with any underlying precipitating cause. Most of the times, infection, that's what we see, urosepsis and all, especially elderly. So that has to be taken care. So then once improves, switch to subcutaneous insulin. So come to adrenal insufficiency. As I think everybody know from right from hypothalamus, pituitary and adrenal, it is HPA axis. That is how CRH and ACTH and adrenal corticosteroids will be released. So I'm not very much going into physiology of glucocorticoids. Probably everybody might be knowing 90% is bound, only 10% is free cortisol. Sir, we'll go to the cases. So why it is important, as I think initially was telling about Addison's disease, the importance of the glucocorticoid lies wherein maintain the metabolic functions, especially the cardiovascular functions also, the blood pressure and vascular responsiveness of the blood vessels being maintained by the glucocorticoids. That is the crux where glucocorticoids being given in septic shock and all. Any adrenal insufficiency, the vascular responsiveness goes down and the patient may land up in a circulatory collapse. That is how you have to, sometimes any patient unexplained circulatory collapse, always think of adrenal insufficiency. That is very important. And everybody know about anti-inflammatory effects because we had used glucocorticoids during COVID a lot, hyperinflammatory response and recovery trial, you know, about corticosteroids role. And it's been divided adrenal insufficiency into primary, secondary and even tertiary depending upon whether adrenal gland involved primarily or otherwise pituitary or hypothalamus, depending upon that it's been divided. But I think everybody know that, but the topic what I want to touch upon is it's more of ICU setup. We will be seeing critical illness related corticosteroid insufficiency. We call it as SERC. So that is how. The most common cause of adrenal insufficiency in Indian context is infectious, and most of the times it can be TB. Sometimes secondary malignancies and secondaries can also be precipitated. And we had seen one patient post-operative developing severe adrenal hemorrhages, landing up in circulatory collapse post-abdominal surgery. We had given as a part of, probably thought of the sepsis and given corticosteroids improved. Later we did a CCT abdomen which showed adrenal hemorrhage to our surprise. So this can be a possibility sometimes. So we'll go through different guidelines. He is the man, is Jilali Anani, a lot of research done by him, especially about the corticosteroids and critical illness related, way back from 2002 till forming the guidelines has been very much involved. And what are the different signs and symptoms of SERC or otherwise as such corticosteroid insufficiency? So any patient presenting with hypoglycemia, hyponatremia, potassium will be on the higher side, hyperkalemia, and if there is obtundation. These are the features when they are present, always think of adrenal insufficiency, very important. So, of course, various guidelines are there. So most of the times the crux is what is our, the practical, what we practice is generally we go for without testing ACTH stimulation, especially in the context of septic shock. The idea is once the patient has been resuscitated, fluid resuscitated well, and you have started probably dual vasopressors, still the patient is not responding, that is where you go for introducing hydrocortisone into the regimen. So, but it has to be early. Nevertheless, it should not be delayed. And most of the times we may not be, if the patient is stable, that is where generally you look at the patient ACTH stimulation test. So it is nothing but administering 250 microgram of ACTH. Prior to that, you will draw cortisol, and post ACTH injection after 60 minutes, we will be looking at the cortisol level. If there is at least more than 9 microgram elevation, it indicates no corticosteroid insufficiency. If it is less than 9, definitely it is unresponsive. Adrenal glands are unresponsive. That is where these patients respond. So most of the trials have been done that. So I'm not going very much into trials. Any role in ARDS? If the steroids have to be given in the context of ARDS, as we were discussing, as I was telling about the COVID, if it is in the early part of ARDS, and possibly that is where the role, but once the ARDS is established and beyond 1 week, most of the times it will not be useful. And definitely in trauma, they are very much contraindicated. If you look at different trials like Corticus trial, Vanish trial, iPress trial, adrenal trial, these all have did not show much of any benefit. Only one study, which is approaches trial. This is where they had given hydrocortisone 50 microgram 4 times plus fludrocortisone 50 microgram. In this, there was a lower 90-day all-cause mortality as compared to the patient who did not receive the hydrocortisone and fludrocortisone regimen. So as I was telling, the same thing, fluid resuscitation, start vasopressors, still not responding. That is where you go for starting the hydrocortisone in this subset of patients. So thyroid disorders. We'll start with case 61-year-old, MODS, multi-organ dysfunction syndrome, secondary to stomach infection, sensorium still to be on the lesser side, blood sent to rule out reversible causes of altered mental status. So TSH, then thyroid, someone did thyroid function test. TSH seems to be elevated 13, free T4 is normal and T3 is low. So what do you think? Do you think this patient is hypothyroid? Anyone? Is this patient hypothyroid? Can anyone comment? Yes. So do you want to supplement this patient with thyroxine? So patient is sepsis in MODS, that is the reason you don't want to supplement. Okay. Or any other reason? Is there any problem with thyroxine supplementation if the patient is sepsis in MODS, or is there any other justification for that? You don't want to supplement?
In sick euthyroid syndrome, we don't give nurse.
Okay. So that's good. So sick euthyroid syndrome, that's what been expected in sick euthyroid syndrome. So I will be going through quickly different what is sick euthyroid syndrome. So it is been actually recently been called as non-thyroid illness syndrome, nothing but. So various different causes, the patients who come to ICU, they can land up in sick euthyroid syndrome. So as everybody know, 99%, more than 99% is bound to TBG as we go thyroid physiology, and 80% is. I am not going very much into these
please,
details.
and time out. So you just focus on sick euthyroid.
So generally in sick euthyroid syndrome, this is what the pattern. If you look at this picture, and this is, I think, should be a take home, where if you look at the thyroid stimulating hormone, free T4, T4, T3. So all have been in moderate or severe or mild to severe, generally they go down. So mild may not be much, but moderate to severe illness, generally they go down, these hormones of thyroid. But if you look at reverse T3, it's been elevated. This is the characteristic of the sick euthyroid or nothing but non-thyroidal illness. So this is what elevated, reverse T3 is elevated, but all others may come down. So there are different studies, especially if they are very much going down. So I will go to one table where this is 80 patients. If you look at the Apache score as it is more, that is more than 20 as compared to suppose 11 to 15, the thyroid, whatever T4, free T4, T3, as compared to these subset of patients, it's definitely on the lesser side. And these are the patient p-value is very significant, and these are the patients who will be very sick, and the mortality will be on the higher side. So the summary is low T3, T4 and free T4 indicates severe illness, and higher mortality is a possibility. So overall, actually speaking, most of the guidelines, they say don't check thyroid function test if the patient is in multi-organ dysfunction, very sick, has come to ICU. So that is how. Why? Because invariably, whatever the pattern we had seen, we get it. And probably you should not be supplementing these patients with looking at just TSH and all, sometimes being elevated, should not be supplemented. So why so? Because this is a adaptive response or protective response in the critically illness. Because if the thyroid levels go down, it actually prevents more catabolism. Because the catabolism has to be prevented. Otherwise, the patient may land up in more and more cytokine storm and all. So, but what happens after 1 week and all, still they are on the lesser side and thyroid function is not resuming, that is probably where you call it as maladaptive response as compared to initial period of time. So various studies have looked at giving even T3 administration and all. Most of the studies, they concluded that there is no difference. If there is a less T3, you give T3, so it's no response. So I can say maybe three principles. One is don't check thyroid functions in patients who are very sick. But if there is some cardiac dysfunction, probably most of the times having paroxysmal atrial fibrillation, probably those are the patients that you check TSH. And if the TSH is too low, less than 0.01, probably it is points towards thyrotoxicosis. And if it is more than 30, probably this patient might be having pre-existing hypothyroidism and they are sick now. And these are the patient may be started with slow, low dose of thyroxine. And the third point is just don't only check TSH. If you want to check thyroid function in these patients, check TSH, free T3, T4, and reverse T3 if possible. So that is how you can come to a conclusion. So I think, most of them been covered. Any doubts?
Yeah, I think, thank you, Kaladhar, in the vicinity of time. You covered it well, emphasizing the important point. I think 5-6 take-home messages which you emphasized is hypoglycemias when reached to your emergency room or ICU, look for their malnourished status, ethanol status, try to supplement thiamine. If you don't have thiamine and somebody is a neuroglycopenic state, don't hesitate to give 25% dextrose because it will be the immediate cause of death. So, but if you have availability of thiamine, do supplement thiamine. And then the second point he made is between diabetic emergencies, when you have a hyperglycemic state, look for whether it is a DKA or hyperosmolar coma and differentiate between them. And probably both of them will add hydration along with that. But he emphasized looking at electrolytes. And we do look at electrolytes and most importantly, potassium. The first one, which most of the times will have on the lower side, and don't give insulin till it reaches to 3.3. Even though your glycemic state is abnormally high, we priorly correct the potassium, then start insulin. The reason is hypokalemia can kill a patient, hypoglycemia will not. So hypokalemia can cause arrhythmias, which can lead to death of the patient, whereas hyperglycemia can wait for some time. So first potassium followed by that. But he re-emphasized phosphorus and magnesium also. So these are the electrolytes: sodium, potassium, phosphorus, and magnesium. In adrenal insufficiency, he said if somebody had all hypos except probably potassium, hypotension, hypoglycemia, hyponatremia, but only one hyperkalemia, then think about a adrenal insufficiency and think about supplementing some steroids by sending a serum cortisol. And he spoke about in intensive care units, when somebody is sick, we do deal with a relative adrenal insufficiency, which has a term itself called CIRSE, and he has actually put a light onto it. In thyroid disorders, we will not go into endocrine problems of hypothyroid and hyperthyroid, but he said many of us send T3, T4, TSH in ICUs when somebody is very sick in the hospital. You will see a variation in all these levels. T3, T4, TSH, they can be low and sometimes TSH can be high. These all are adaptive changes of thyroid gland. They may not mean anything when it comes to diagnosing a hypothyroid or hyperthyroid. So please do repeat them after the patient gets normal, maybe after a few weeks of time. And these are adaptive changes of your body to the need of that critical illness. Don't treat them. Sometimes treating them with thyroid hormones can cause a collateral damage than benefits. That's what is the studies told. I think with this carry-home message, we'll take to the next talk. That will be by Dr. Mallikarjun, who is...
Thank you, sir. Thank you, FDRS and Faraz sir and Srinivas sir and
Thank you,
Venkat sir,
Kaladhar,
Bhavani
for
sir
your
and
talk.
Mansudhan sir for the opportunity.
So Dr. Mallikarjun is our senior consultant, a lead consultant in the Department of Critical Care Medicine in Premier Hospital. And he has graduated, post-graduated along with me in Usmania Medical College. and happened to done his post graduation fellowship in Sri Chitra and done his critical care fellowship in Care Hospital. So he will take us to. So if you see these three scenarios which we created as a critical care symposium, one is ABG interpretation, the other one is endocrine emergencies, the third one we actually spoke about a approach to a patient with shock. So somebody who is having a low blood pressure comes to you, to either your ER or your hospital or to your clinic. How do you respond? I think Dr. Mallikarjun will take us through that. Over to you, Mallikarjun.
Thank you for the kind introduction, Dr. Venkat. So I think I have been done some injustice because this is a 1.5 hour topic to be covered in 15 minutes. I think we need to really rush through. Okay, so just go through this first case. So this is an RTA, a 54-year-old patient, RTA, no major head injuries or any other extremity injury, but he had an abdominal crush injury where he had a splenic rupture, so for which he underwent a laparotomy. So he had no other comorbidities, etc. So he underwent an emergency laparotomy and splenectomy, and he was quite okay till the next 5 hours. But after that, he suddenly started dropping his pressures and he became unresponsive, less responsive, heart rate started jumping up, and there was increasing oxygen needs. And when the surgeon examined, there was like the abdomen was soft, there were no new collections, and the dressings were dry, and his capillary refill was quite okay, and the skin was quite warm to touch, and ECG was normal. And when labs were drawn, it showed an elevated lactate. So that was a abnormality which was found. And then he went into a DIC stage. So now, what type of shock would you consider as the most probable in this case of scenario? So just keep this question in your mind, and let's go through the next few slides, and probably then you can answer this question. So what is the definition of shock? So shock, it is basically a mismatch between the oxygen supply and the demand to the tissues. Okay. So the single most important equation which we need to know is the arterial oxygen delivery. What is the arterial oxygen content? And then, so when we see the formula, it is DO2 is equal to cardiac output into the arterial oxygen content. So the cardiac output itself is dependent on the heart rate and the stroke volume. And the stroke volume in turn is dependent on the preload, cardiac contractility, and afterload. So, and then the arterial oxygen content, it depends on the bound hemoglobin, bound oxygen and the dissolved oxygen. Okay, so it again depends on the hemoglobin levels and SpO2 levels. Why I am stressing on this particular equation is like these are the crucial points where we find the actual problem and the intervention which can be done. Okay, so when you see the mechanism of shock, it is basically impaired oxygen delivery due to a circulatory failure. So others could be where is an inappropriate increased oxygen consumption or decreased utilization. So ultimately, it all results in deviation of the regular metabolism from the aerobic to anaerobic, and where instead of acetyl-CoA and ATP is being generated, it moves on to producing lactates and resulting in decoupling of the enzymatic processes and finally cell death. Okay, so why is it very important to recognize shock early? Because that is the way the shock progresses, you really don't, it doesn't give you time. The patient just goes on from a reversible stage to an irreversible stage, then organ dysfunction, and finally death. And this all can happen really quickly. And so early detection and treatment is really crucial for survival. So what are the pitfalls in shock? So problem is like it is not a blanket syndrome where it has a uniform sign or symptom or a specific lab parameter which can diagnose sensitively or specifically shock. And it has a very, very wide presentation, varied presentation, which really depends on the patient's background, the diseases, and how they have been managing and controlling their disease. And another complication is like the shock itself has got multiple types, and they can occur in mixed forms, like they can overlap very greatly. So it's very difficult to really differentiate a shock. So initially, a lot of patients, we get undifferentiated shocks. So basically, recognition of shock, it requires a clinical judgment and based on constellation of signs and symptoms, and supplemented with our bedside evaluations and lab analysis, we'll have to come to a proper diagnosis of whether it is a shock and what stage we are in and how we can bring him out. Okay, so the staging of shock can be like initially it will be an occult shock, like, or pre-shock, some people call it, or a cryptic shock, where there will be very subtle changes like a rise in heart rate, or a rise in respiratory rate, or a drop in saturation, or a small rise in the lactates. So all these we might ignore, but these are the places where we should be catching them and treating them. And the next phase would be a decompensated phase, where they go into a frank overt shock. So where more than two organs get involved with moderate increases in all the above parameters, and then they go on to a frank organ dysfunction, like sudden stoppage of the urine, sudden drop in pressure, and they have cyanosis. Then ultimately they can have arrhythmias and even death. Okay, so grossly we can divide shock into 4 categories. So the distributive shock, hypovolemic shock, cardiogenic shock, and obstructive shock, of which distributive shock is the highest incidence. Okay, so this is an overall picture depicting how the shock has been classified. So when you note the center of it, it shows that all the shocks boil down to basically oxygen discrepancy between the oxygen supply and demand, and they can be grossly divided into like distributive shock, hypovolemic shocks, cardiogenic shock, and obstructive shocks. So when you see hypovolemic shock, that's the simplest one, where you have either blood loss. It could be either because of a trauma or just another non-traumatic blood loss. So these can lead to a drop in the preload and drop in the stroke volume and drop in the cardiac output and result in shock. And next would be a distributive shock. Distributive shock, so the commonest is the septic shock. So this is almost like the major chunk of patients which come to our ICU. So invariably, when you really feel when a patient just comes into your ER and into your ICU, and you see that you're not really able to make out what is the cause, then you can safely assume that it could be a septic shock and start antibiotic as well. And meanwhile, you work up for what is the cause. Okay, so in addition to the septic shock, there is anaphylactic shock, then anaphylactoid shock, and neurogenic shock, and endocrine shock. So all these come into distributive shock. So where there is an increased cardiac output initially, so because of drop in the systemic vascular resistance. And yeah,
We'll try to go into the cases if we have, and then
not this one. So next would be the cardiogenic shock, where the different phases of the circulation, like one is the pump failure, like in an acute MI or something, you will have a direct damage to the myocardium resulting in a cardiogenic shock. Then arrhythmias, bradyarrhythmias, tachyarrhythmias, which can result in shock. Then there could be obstructive pathologies like stenosis, or there is a sudden regurgitation components. So all these can also result in cardiogenic shocks. And finally is the obstructive shock, where it is either there is an LV OT obstruction, or there could be something like a pulmonary embolism. So all these can also result in a shock, where there is a sudden increase in the afterload leading to drop in the cardiac output. Okay, so this is again just all the various shocks. Okay, so this is very, very important. So the pathophysiology of the different forms of shock. So in distributive shock, the primary problem is a decreased SVR. So this can result in a increased cardiac output. So this is the only shock where you have an increased cardiac output. And septic shock is the one of the major chunk of distributive shock. And then you have the cardiogenic, obstructive, and hypovolemic shocks, where you have all of them have the primary problem as cardiac output decrease in the cardiac output is the primary problem, and this results in an increased SVR as a compensatory mechanism. So we can also see the how the central venous pressures and the PCWP change. Okay, so the main problem, as we already told, there is no single diagnostic test for shock, and a normal BP does not rule out shock. So in case there is a hypertensive patient who has been used to 180 pressures, and if he comes to the ER with a 100 or 120 pressures, he could very well be in shock, and we might miss it. And normal mentation too does not rule out shock. So a lot of patients in septic shock, usually they present with altered mental status and all, but cardiogenic shocks, usually they are very well preserved till the end. And next, high cardiac output too. So again, the cardiac output doesn't say that, so there's a good cardiac output, so he's not in shock. It could be a high output cardiac failure. Okay, so and that's one. So various patients with different forms of shock will present differently. And again, that depends on their underlying comorbidities. So the take-home message should be, I think, clinical judgment based on the constellation of signs and symptoms augmented by bedside imaging and lab analysis. So that should be our guide to identifying the shock. So again, time is tissue. So don't wait for getting a complete history and performing a full detailed examination and then identify, okay, this is shock, then we treat it. No, you just start stabilizing the patient just like how you do with an ABC approach and go on. And in the meanwhile, just history, physical examination and investigations will definitely help you. Okay, so our goal should be a confirmation of the shock and identifying the type and treat it specifically and catch them in an early stage. So from the history also we can identify what is the problem organ. So and what is the probable shock. So for instance, this is a scenario like where you have the patient with a history of fever and has a foot cellulitis or something. So that is straight away, it is a distributive shock with a source of sepsis. Okay, then hives, presenting with hives, facial edema and dyspnea after exposure to allergen, it could be an anaphylactic shock. And the third one is like he has an exertional chest pain, then palpitations and syncope. Then it could be a cardiogenic shock. Then there is a fourth one is like they have a straight away history of trauma or a massive GI bleed which is just occurring in front of you. So that could be a straight away hypovolemic shock. And the hypertension with a tearing chest pain and back pain, it could be. Any guesses?
Dissection of aorta.
Yeah, it could be an aortic dissection. Okay, so again, coming to the history and data review, when you really see all the history, you have to ask for history of specifically VTE, then whether they were on any immunosuppressives, they had any urinary catheters or any other dialysis catheters, which could be a source of the sepsis. Then any recent procedures or trauma, so that could be a source of sepsis or hypovolemia and all this. Okay, so basically clinical presentation. So when the patient presents, we should see how their hemodynamics are, and don't go by the absolute numbers, go by the trend of the data always. And there is one component, shock index. So shock index, it is basically the heart rate by SBP, and modified shock index is mean arterial pressure. So heart rate by mean arterial pressure. So that will give us an idea like where he stands and how bad is the shock. Okay. So other symptoms which we can note are the tachypnea, oliguria, then a sudden change in mental status. So all these can be like subtle changes which will be indicating that the patient is dropping into shock. Okay. And one more important thing is when you see by the bedside, the skin perfusion is really, really important. In a resource limited setting where you don't have much of equipments and all, just touching the patient with your bare hands will tell you a lot of information. How whether their peripheries are very cold and vasoconstricted, and the capillary refill time. If it is more than 5 seconds, it suggests impaired perfusion. And mottling, again, just lift their clothing and see their knee joints. So that is a very important sign. So where you'll see grading, so that is like, or here you have different grades are there. So right from the pertaining to the knee joint, then to the upper end of the patella, and then up to the mid thigh, then groin. And if it is extending beyond the groin, the mottling, that means he is in a very bad shape. Okay. And lactates, again, not to undermine, lactates are really, really important. And anything, any increasing trend of lactate should be a warning bell for you to start treating aggressively. And another, in case your lactates are not available on your ABG, even an anion gap definitely helps, increasing anion gap. And this is a illustration of the bedside shock evaluation. So where you see from the monitor, you see the arterial waveform, the curves, the pulse pressure variation. All these will give you an idea like whether the patient is hypovolemic or what is happening. And echo definitely gives you insight into the cardiogenic shocks and volume status, all this, and even the IVC. And lung ultrasound will tell you like whether the patient is already in a state of fluid overload and whether he will accept any more fluid, and is it dangerous to give a fluid challenge and fluid bolus. And abdominal ultrasound again to identify any hemorrhages, and the skin perforation, of course. Okay, so investigations again, lactates. And then based on the septic, if you suspect sepsis, then urine cultures, urine analysis, and all these are required. And radiological investigations, again, as per the patient, we'll have to do. And do not neglect the POCUS. So that is a very, very important upcoming trend now. Okay, so again, so management should be, again, try to do the ABC, like try to keep them, and then the circulation also. Okay, just establish good IV cannulae and then fluid boluses as per the shock, like whether it is a volume depleted patient, and or if the patient is already in suggesting that he is in a volume overload state, then be very cautious and keep giving intermittent fluid challenges, and then keep reassessing very frequently. And ultrasound is always really beneficial in this thing. And vasopressors. So when do you start vasopressors? When do you start inotropes? So pressors, so earlier we used to keep the idea that you have to give a adequate fluid bolus, and then you start the vasopressors if there is no response. But nowadays it is like you have to start everything simultaneously. Just start the fluid bolus, and then if you don't see the response immediately, start administering vasopressors, and gradually, once the BP picks up, you can start weaning it off. And till you find a particular source of the actual sepsis and cause for the shock, try to treat it. And and of course, antibiotic administration, the early administration plays a crucial role. And in the history itself, we will be seeing that some of the patients are already chronic abusers of steroid. So such patients, again, you'll have to suspect adrenal insufficiency, as Dr. Kaladar also reiterated. So we'll have to probably start them on steroids. Okay. So, and once we identify a specific problem, then we have to direct the therapy. Like in cardiogenic shock, you'll have to take them to the cath lab and do
We'll
it.
go to last summary.
Yeah.
So I think, thank you, Mallikarjun. Actually, it is a very short time to actually talk about the whole of SOC. So in a take-home message, probably I will talk to you about three ways of actually identifying. You all see if a patient comes to you with low blood pressure, you always think about, is there a possibility of low perfusion to this? And to know the low perfusion in these patients, we have windows. As we said, ki the head to toe, the brain is one window, the skin is the second window, kidneys and urine output is the third window. If a patient is low in blood pressure and he is on altered mentation, he says he's confused or he's not been normal in coherence. Second, if his skin is cold and mottled and your extremities are extremely cold and he says he's a decrease in urine output, these are the patient whose probably the perfusion is not adequate and they are into possibly landing to multi-organ failures. So these are the patient where we considered them to be SOC. As Mallikarjun tried to actually explain you all those things, initially to differentiate between all the SOCs may not be easy in all your clinics or in the periphery center or in the hospitals, but securing a large bore cannula, initiating a fluid bolus, starting a vasopressor and trying to send this patient for an evaluation is the need of the hour. I think that's what will be my take-home message for you. Thank you, Dr. Mallikarjun, for this. I think in the vicinity of time, we'll hand over this. Thank you.
And this one looks like an SIRS. So probably because of the crush injury,
Yeah.
the answer. So it is a septic shock.
Okay, thank you, respected chairpersons and speakers. It was a very knowledgeable session. I request all the panel members and the speakers to please gather at the selfie booth of Critical Care Symposium. Panel members and speakers, please gather at selfie booth for felicitation. Not announced. No need. No time on that. So moving on to our next session, latest updates in medicine. I would like to call Dr. A.K. Tiwari, Dr. Pratima Raj, Dr. Sriram Abkari, and Dr. Aftab Ahmed to the stage. Dr. A.K. Tiwari, Dr. Pratima Raj, Dr. Srirang Abkari, and Dr. Aftab Ahmed. I request you please join the stage for panel. Okay. The chairpersons are requested to invite the speakers. Thank you. We'll take all our stuff and leave. And one more request. I request all the chairpersons and the speakers to please maintain the time. Thank you.
Hello, a very good morning to all of you. So we are going to move to the most exciting part of the program, that is the debate. And to debate on to treat or not to treat subclinical hypothyroidism, we have two giants, Dr. Supratik Bhattacharya from Kolkata. He will be speaking in favor of to treat subclinical hypothyroidism. And we have an able opponent, Dr. Balaji Jagan Mohan. He will be speaking against the motion. So I would request Dr. Supratik Bhattacharya to start. So we'll have 12 minutes for each, and thereafter the first speaker will be given 2 minutes for the rebuttal, and thereafter we will have the conclusions.
Thank you, Chairperson, for all your kind words of introduction, and a warm welcome to all of you. Thank you, Dr. Faraz, Dr. Srinivas, Dr. Alim, Dr. Moshin, for this invitation, and it's lovely seeing all of you. So I'd be speaking in favor of why and when to treat subclinical hypothyroid. Now, let's look at this picture and then decide. So in life, you have choices, and at the time when you're standing and trying to make a decision, you come across two choices. And this is exactly where we stand today, to treat or not to treat. So what is subclinical hypothyroid? I'll just briefly summarize regarding the definition, and I'll explain the situations, and I'd say it's majority that you'd need to treat. So if you see there's a persistent elevation of TSH levels more than 4.5 and less than 10, with normal free or total T3 and T4 levels, with few or no signs or symptoms of hypothyroid, that is called subclinical hypothyroid. Now this is, as we said, is the definition. So anyone with a TSH more than 10, you need to treat, period. So there is no controversy regarding that. But you have to make a choice, a clinical decision, whether or not to treat a TSH level, which lies between 4.5 and 10, with normal free T4, and depending on whether they're symptomatic, whether they have positive anti-TPO antibodies, whether there are special situations where the person is planning to undergo pregnancy or conceive. So there are many situations, and I'd say majority of the times you'd need to treat the patient. Now, let's look at this particular lady. She is a 29-year-old newly married female complaining of mild depression, dry skin, and hair fall, which are considered symptoms of hypothyroid. The physical examination is unremarkable. There is no goiter. Body weight is 68 kilos, converting to a BMI of 26.5. The labs are usually normal, with exception of the cholesterol, where there is dyslipidemia. And TSH is 8.9, free T4 is 1.1, anti-TPO is positive. Should you treat this lady? Just a raise of hands. How many would you want? How many of you would want to treat this subclinical hypothyroid patient? So I think majority of us agree that this is a situation where we need to treat. So management of hypothyroid, we know that TSH is a must for diagnosis and monitoring. Free T4 hypothesis, only free hormone metabolically is active and determines the thyroid status, and gold standard is to do a equilibrium dialysis. Now, we have to rule out the conditions which cause transient increase in the TSH level, and you have a whole list of things which I'm not going to list out. It's there on the screen at the moment. So causes could be a transient increase in the thyrotropin levels, and also causes persistent increase in the thyrotropin levels combined with normal or free T4. That could include things like obesity, adrenal insufficiency, etc. Now, why we need to treat? Because we know that there is a very high chance of conversion of subclinical hypothyroid to a overt hypothyroid state. And the average yearly progression rate is anywhere between 2 to 6%. The risk is more if it is a lady, if the individuals have a higher levels of TSH, and there is a presence of anti-TPO antibodies. So these are all the situations where the progression to an overt hypothyroid state is more. Let's look at the cardiovascular risk in subclinical hypothyroid state. So if you look at the cardiac function in subclinical hypothyroid, the most consistent cardiac abnormality reported in patients with subclinical hypothyroid is impaired left ventricular diastolic function. So it's pretty much a very common echo finding for any subclinical hypothyroid patient that you see. Subclinical hypothyroid has been associated with an increased risk of fatal and non-fatal chronic heart diseases and events. And we know that if you look at the hazard ratio, it's clearly more as compared to the normal cohort. Risks of heart failure events were increased with both higher as well as lower TSH levels. So whether the person is having a TSH between 4.5 and 10, We know that even in the subclinical hypothyroid state, the chances of a heart failure event was more as compared to those who had a TSH less than 4.5. Subclinical hypothyroid is also associated with adverse prognosis in heart failure patients. So anyone with heart failure, with a background of heart failure with subclinical hypothyroid state, again, you need to treat them because the prognosis is worse in those with subclinical hypothyroid. Meta-analysis of 16 observational studies show higher total cholesterol values. So obviously one of the things that we look into is whether the person is having dyslipidemia, and that us to treat subclinical thyroid. And we have data suggesting that if we treat the subclinical hypothyroid state, this dyslipidemia gets better. And clearly we do have a randomized controlled trial, which shows that if you're treating subclinical hypothyroid with thyroxine, the dyslipidemia gets better, and there's beneficial effects that are seen when you're looking at the lipid endpoints. Also, there are increased mortality in subclinical thyroid state, which gets better with treatment. So long-term untreated subclinical hypothyroid can cause hypertension, cardiovascular abnormalities, endothelial dysfunction, which is a common soil for both micro as well as macrovascular events, increased arterial stiffness, dyslipidemia. So all of these will drive increased cardiovascular morbidity and mortality, leading on to coronary heart disease, heart failure, and atherosclerosis. If you look at the carotid intima media thickness, which is a surrogate marker for a future cardiovascular event, and metabolic parameters, looking into the reduction with levothyroxine treatment in subclinical hypothyroid, you clearly see that the chances of a cardiovascular event going by the surrogate marker or the carotid intima media thickness was more in the subclinical hypothyroid as compared to those who are euthyroid. And if you're treating with levothyroxine, this parameter got better. So now coming back to the same lady who we decided that we were going to treat, and we are pretty much unanimous about this decision that we needed to treat that lady based on the lab parameters and the features that we had. So we had started her on levothyroxine 50, and she's now coming back to you with a TSH of 4.4 and a free T4 of 1.2, and she says that she's now planning to conceive. So are we happy with this TSH level at this point? So we know that there are various ethnic cutoffs, and one shoe would not fit all, but there are some guidelines that will drive us to determine the TSH levels trimester-wise. So we know that the beta HCG causes thyroid stimulation from the first trimester due to structural analogy with the TSH, and decrease in the serum TSH is seen in the first trimester. So pregnant women have lower serum TSH concentrations than non-pregnant women, and increased renal clearance, fetal intake, and placental metabolism induce a relative decline in the iron levels. So these are the changes that you see during the pregnancy, and this is normal and physiological. And the physiological changes are various that are listed on the screen. Because it's a debate and we have shortage of time, so would not go into the details of this, but it's good to know what you have on the screen. Now, we have to carefully interpret the TFT during pregnancy. During early gestation, TSH decreases by 20 to 50% by 10th week. And in the first trimester, the normal range of TSH is reduced to about 0.1 to 2.5. Maternal TSH does not provide a good indicator of thyroid status in first trimester unless trimester-specific range is available. And TSH remains the best measure of thyroid function during the second and third trimesters. So these are the guidelines. 2017 recommendation of ATA of a revised URL for TSH of 4 is considered as high. So we should instead be using 3 as the cutoff for the first trimester and 3.5 in second and third trimester. So if you look at the FOXY criteria, I'll show you the FOXY criteria as well from India. So they say that first trimester it should be 2.5, second trimester 3, and third trimester 3. So this is generally what we go by. But there is another paper by Dr. Sanjay Kalra et al. Showing that there might be ethnic differences, and we might go for a slightly higher cutoff during the various trimesters. So in previously diagnosed hypothyroid women, TSH should not be higher than 2.5 before conception and may require to increase dose by at least 30% or more during pregnancy. Increased requirement occurs as early as 4 to 6 weeks and gradually increase through 16 to 20 weeks. So management of hypothyroid, yes, TSH should be monitored and checked at least between 26 and 32 weeks. And the goal is to normalize the TSH to the trimester-specific range that we had been talking about. So is thyroid dysfunction in pregnancy an important issue? Yes, because it can cause hypertension, preterm birth, low birth weight, placental abruptio, and fetal death. And 3 times more likely to be complicated by placental abruptio, preterm birth almost 2-fold higher, severe preeclampsia. So clearly we do get a message that if you have a subclinical hypothyroid state during pregnancy or preconception, we need to treat that condition. We can't just let it go. So perinatal outcomes, delivery and neonatal variables, you can clearly see those with subclinical hypothyroid state versus those who were euthyroid had a worse outcome during pregnancy and during the delivery as well. So effect of anti-TPO antibody, 7.9% of the women had hypothyroid. Amongst them, anti-TPO was positive in 40%, and threatened abortions, spontaneous abortion, preterm delivery, fetal malformations, IUGR, everything was more in those who had positive anti-TPO antibody. So universal screening has been recommended by most of the societies, including the Indian Thyroid Society. And I see Dr. Zargar here, and he has been part of this guideline as well. And if you look at the combined ITS and FOXC 2019, they say that all pregnant females should be screened at the time first antenatal visit. Now coming to another important issue about subclinical hypothyroid in the elderly individuals. Again, this is a lady who comes with similar TSH values around 8.9 and free T4 is 1.2. Should we be treating this condition? So again, the controversy lies because we know that the set point increases with age, and we have to make a decision based on the age. So anyone less than 65 years or even 70 years, we know that we get benefits in terms of having lesser cardiovascular events if they're treated and if they are between 40 and 70 years. We don't have much evidence of getting benefits in terms of treating subclinical hypothyroid in those who are more than 70 years. So decreased all-cause mortality if the age is between 40 to 70 years. And general therapeutic approach to management of subclinical hypothyroid in non-pregnant women should be, if the TSH is more than 10, they're symptomatic, you need to treat. There's no sort of ambiguity about that, even if they're elderly individuals. But if they're less than 65 or even 70 years, coming with subclinical hypothyroid, you might get benefits in terms of the cardiovascular endpoints. So the factors favoring levothyroxine treatment are, if you have, goiter, if you have anti-thyroid antibodies, if there's a progressive increase in the TSH, young age of the patient coming with comorbidities like diabetes, if they're intending to conceive, patient preference, dyslipidemia, infertility, cardiovascular risk factors, all of these. So pretty much majority of the patients with subclinical hypothyroid would probably qualify. So you see, we had mentioned that anyone between 4.5 and 10 would be considered subclinical hypothyroid, and all the reasons to treat would be those having multiple symptoms, positive anti-TPO antibody, progressively increasing TSH, planning for pregnancy and goiter, and anyone less than 70 years who might benefit from treatment in terms of the cardiovascular endpoints. So clear take-home message is subclinical hypothyroid leads to alterations in cardiac contractility, vascular function, and lipid and lipoprotein metabolism. And we have seen evidence that if you treat with levothyroxine, that can, revert some of these symptoms and benefit the patients in terms of the endpoints that we were assessing. So thank you, and I think I have made my point.
Request Dr. Balaji to kind.
Thank you, first of all, Dr. Faraz and the entire EPTAS team for having invited me for this talk, in fact, for this debate. Just coming to the first slide, I think what my opponent has shown, Dr. Supratik. So he showed us a path where you either treat a patient, you don't treat a patient, but there's also something where we can always wait and watch. So there is a third part that exists, and probably I'll try to throw more light on whether we can wait and watch. So as you're aware, I'm going to talk about whether subclinical hypothyroidism, not all forms need treatment, is something that I will talk. Now, already this is something that we are aware. Subclinical hypothyroidism is characterized by an increase in TSH. It can be anywhere between 4.5 to 10 and a normal free T4. But there are certain instances or cases where the TSH can be more than 10 and the free T4 is still normal. And the subclinical term implies because it is a laboratory diagnosis, not all SCH patients will come to you with symptoms. We'll have to do a lab workup, we'll have to see for the antibodies and the thyroid function to determine whether they have SCH. And the link to develop overt hypothyroidism is uncertain. If you see the progression to overt hypothyroidism, it is around 4% per year if they have anti-TPO antibodies positive. If they do not have antibodies, then the progression rate is much lower. It is only around 2%. So there is an ambiguity. So there is an equivocality as far as subclinical hypothyroidism is concerned, because the tests are not very comprehensive. Many a times when we do a thyroid function test, we ask for a total T4, T3, and then a TSH. Very seldom we do a free T3, a free T4. Sometimes we even miss to do an anti-TPO or an anti-thyroglobulin antibody. And still there is a lot of controversy as far as the accepted range is concerned from the various guidelines. So there is this ambiguity as far as diagnosis of subclinical hypothyroidism is concerned. So diagnosis, how is it made? So first of all, the patient has to be in a steady state condition. We've seen in many emergencies, there can be a rise in TSH. So those can be false positives. There are several other false positive states. Patient has to be stable. So transient increase in TSH elevations can occur in several non-thyroid illnesses, especially postpartum. It can be drug-induced, amiodarone, mood stabilizers, they can cause a transient increase. So all these conditions have to be kept in mind so that we can rule out a transient increase in TSH and then label as a subclinical hypothyroidism. Now, is this patient having hypothyroidism? That is the question. Now, if you treat any patient who is suspected to have subclinical hypothyroidism prematurely with levothyroxine, it can go to the other extreme. They can manifest with symptoms of hyperthyroidism. They can lose weight. There can be an increased restlessness. It can, in fact, increase the risk of certain arrhythmias. And if you see the data, non-specific symptoms like fatigue is very common in the general population. A lot of our patients come to us and they complain of fatigue. That does not mean that we need to necessarily correlate with HCH. 25% of the euthyroid population may have thyroid similar symptoms. So again, we confuse the symptoms. If medication is prematurely given in subclinical hypothyroidism, it can land up in other symptoms of hyperthyroidism. So we have to be cautious. Now, this is a nice table. You can have a look. I think my opponent has shown this. If you have a TSH which is under 7 and the age is less than 70, monitoring is recommended unless they have symptoms, unless they have antibodies, you should not be treating the patient. If they're above the age of 70, there's a physiological increase in TSH, so we do not have to treat these patients. We can monitor them over a period of time. If the TSH is between 7 to 10, again, symptoms persistent, antibodies, or if they're high-risk groups, they come with a goiter, pregnant woman, already they have cardiovascular disease, then you might have to treat the patient. Elderly patient, again, you don't have to treat. Monitor them between 7 to 10. If there are persistent symptoms, you might consider treatment. Now, if it is clearly above 10, irrespective of the age, you might have to treat the patient. Now, these are the various guidelines. They've given recommendation for the treatment of TSHs above 10. Now, there's a very interesting thing here, the desiccated thyroid extract. Desiccated thyroid extract is normally derived from an animal source. We don't use it very often, but it's a combination of T4 and T3 in a ratio of 4:1. So the dosage of 65 microgram is equivalent to 100 microgram of levothyroxine. Most of the international guidelines are against the use of DTE because it increases the risk of side effects. The patients can go into a hyperthyroid range. So here, most of them recommend that only above a TSH of 10, we need to treat the patients with levothyroxine. Now, these are some of the data of initiating treatment in subclinical hypothyroidism. Now, there is a meta-analysis, and it was seen that there is no improvement in the quality of life, the cognitive function, blood pressure, or even the BMI if you substitute treatment with levothyroxine in patients with subclinical hypothyroidism. There was another study, this is the Greek study, in patients who had already ongoing hypothyroidism, where the initial diagnosis was uncertain, whether they had HCH, overt hypothyroidism, and they re-evaluated the treatment. So it was seen that in 291 patients, median age of around 48 years, the treatment with levothyroxine was withheld because many of them were going into a hyperthyroid range and having the other symptoms. After 6 to 8 weeks, 61% had normal euthyroid function, so they had to withdraw the levothyroxine. In another randomized trial of older individuals, there was absolutely no relief of the hypothyroid symptoms after pharmacotherapy with levothyroxine. So looking at the risk-benefit ratio, what is the benefit of treating a subclinical hypothyroidism with levothyroxine? Mostly people who are less than 70 will benefit. Pregnant women, definitely I agree. You have to keep the TSH less than 2.5. Women who are infertile, if they have a symptomatic goiter, you have to treat. Anti-TPO, anti-thyroglobulin antibodies, and people who have a high risk of cardiovascular disease. But what are the risks for treating with levothyroxine in an HCH patient? They can land up in tachycardia, they can have atrial fibrillation, heart failure. There are a lot of studies that point out if you give levothyroxine in SCH, that can increase the risk of heart failure. Fracture risk, pre-existing osteoporosis can worsen if you give levothyroxine, especially if they're taking chronic steroids, and other psychological conditions and severe anemia if you tend to overtreat. So these are all some studies which have looked at subclinical hypothyroidism and mortality. Now this is a meta-analysis in almost 26,000 patients, out of which 2,000 of them had subclinical hypothyroidism, and it really revealed that there was an increased risk of these patients having coronary artery disease. Now what did the data show? All the patients who had a TSH more than 10, only those patients had an increased risk of developing coronary heart disease. Patients who had a TSH between 4.5 to 6.9 were not associated with an increased risk, which means if you treat them as well, you're not going to get any benefit in trying to reduce the cardiovascular outcomes. What about subclinical hypothyroidism in elderly? Already my opponent has pointed out, there is a physiological increase in TSH in elderly patients. And there are a lot of studies which have shown that there is no merit if you substitute levothyroxine in elderly patients who have an elevated TSH. In fact, there is no better outcome in terms of quality of life or more longevity if you give levothyroxine. He did show the first case, the young lady who came with depression. Now, depression symptoms and hypothyroid, subclinical hypothyroid symptoms can mask each other. There is this data, if you see, there is a study that was collected for a period of 2 years in 93 than 10. They were treated and brought down to the euthyroid levels, but there was no improvement in the depression symptoms despite bringing the TSH levels to normal. So looking at some other data, now these are all some other data which is seen that if you give levothyroxine in TSH levels and keep it between 0.3 to 2.5, there is no data to suggest that there is an improvement in the quality of life, the well-being, or in some cases the improvement in hypothyroid patients. There was a Dutch study where here again they had given levothyroxine and they've used certain questionnaires. They've used the checklist 90 and the RAND Health survey, and it was seen that there was no improvement in the cognitive function, the mental health, and vitality of patients who were given treatment with levothyroxine. So to conclude my talk, I would like to say that most patients with hypothyroidism, overt hypothyroidism, they feel better if you give levothyroxine. But recent studies have shown that milder forms do not require treatment. You'll have to wait and watch, and there's no improvement in the weight or the quality of life. Lifelong medication with levothyroxine should normally only be considered in overt hypothyroidism. In HCH, only if the TSH is more than 10, you have to give levothyroxine. In milder cases, as mentioned by ATA, 4.5 to 10, a wait and watch. So we do have the third approach. We'll have to wait and watch. Some patients who have high cardiovascular risk, they might benefit with levothyroxine if they have SCH. And in milder forms, it is always good to withdraw the treatment once they go into the euthyroid range. Because if they go in the hyperthyroid, that automatically increases the risk for heart failure and arrhythmia as well. And if the patients have persistent symptoms of tiredness, weight gain, and even if the thyroid function is normalized, we'll have to look at other causes, lifestyle causes, anemia, depression, and other conditions that can mask the symptoms of hypothyroidism. So lastly, I'll just show you this case vignette. Now I had the 68-year-old female patient. She's a pre-diabetic obese, and she came with complaints of occasional tiredness. And I asked her to do a thyroid profile. So you can see HbA1c is 7.1. The TSH is 7.97. Vague symptoms of tiredness. T3, T4 is missing here, which is also normal. And you can see the antibodies for her, absolutely normal, anti-thyroglobulin and anti-TPO. So here, we don't have to treat this elderly patient. We can have a wait and watch approach. Thank you for a patient hearing.
Would request Dr. Supratik to kindly give a rebuttal.
So the whole point of these debate sessions are not to confuse you, so that the idea is so that you can go back with a clear message in mind. And we can clearly agree that both of us had more of agreement than disagreement. So we know clearly the pointers towards treating subclinical hypothyroid, and hopefully by now you have understood what are the places where you can wait and watch. So one shoe doesn't fit all. We are talking about precision medicine. We are talking about individualization and customization. And exactly that is what we do in clinical practice. So you have to go case by case. And it's not like every single subclinical hypothyroid you have to treat. And it's not like every single subclinical hypothyroid you can not treat. So it's about picking and choosing the right profile. But mostly, as I said, majority of them will fit into the zone where they would benefit from treatment. So anyone with subclinical hypothyroid with positive anti-TPO antibody, those coming with more than one symptoms that might be benefited with treatment. If they have a cardiovascular background, increased lipid levels, dyslipidemia, that will get better. If they are, as we said, if they are having a background of heart failure, although he mentioned, but it's mostly in the elderly population, but in younger individuals, we do have robust data that the heart failure endpoints also get better. With this, thank you.
So thank you, and I would request both the debaters to come on the dais. So, yeah, please. So we will not have any raising of the hands for the two, because finally the science has won, and both of them have very clearly defined where we have to treat, what are the values, where we have to look for more frequent testing, and beyond 10 we have to go for the treatment, and the conditions where we have to treat when it is below 10. So I think the message is very clear, and both of them are the winners, and ultimately the science wins. Thank you.
So we move on to the next topic, life behind numbers, time in range, an important parameter which has been discussed recently very much. Children living with diabetes. I request Dr. Vijay Jaiswal to come over the stage and deliver his talk, please.
So thank you very much, and a wonderful good morning to all of you. So first of all, thanks to Dr. Faraz and team FDRS for your kind invitation. You must be thinking that why I am here. So I'll give two reasons that why I am here. Reason number one, that Dr. Faraz is my friend. Second, that pediatric endocrinologist still a rare variety, and most of the patients of diabetes are going to be taken care by you. So joining hands together, how we are going to make this misty picture to a clear vision of diabetes is my agenda of the talk. And of course, back to basic, that there are 4 pillars, that is glucose monitoring, the most important, because if you don't know that what is the speed of my car, then how I am going to have brake and other things. Second, the diet, exercise, the insulin, because I don't use any oral hypoglycemics, and the 2 central breaks, that is the timetable, and of course the education. The education is part and parcel, not only in terms of pharmacotherapy, but even I can have a good quality of sleep during the night. It is really important to counsel the parents for a good management of diabetes. So 3 core technology, and as we have moved from the dialing phone to the 5G, the same is here, that from HbA1c to the finger prick testing, and now with AI, we are here with continuous glucose monitoring. So what are the limitations? Why this is going to be that A1C, which was standard of care, but there were some issues that impact of hypoglycemia and hyperglycemia were unknown. A very common finding, the two person can have with the same HbA1c of 8. Some may have a very early cardiovascular manifestation, and the second one may not be there, being with both same HbA1c. So we'll discuss later slides. The second, that is, if you really want to have a pizza for a child living with diabetes, then we should know that how much insulin is to be injected. Hypoglycemia and hyperglycemia are often missed because this is a point of care. overnight data is impractical and logbooks are difficult to interpret and may sometime they are going to write down all the data within a single day. So you have to be cautious about that. The third, that is continuous glucose monitoring, which provides significant amount of glucose data. However, low penetration due to lack of reimbursement, high startup cost, and reports can be difficult to interpret and gain insight. But yes, this has to be in the later, even in the coming years. So this is a continuous glucose monitoring system. It's a device that records glucose levels throughout the day and night. 288 glucose measurement every 24 hours. So this is, I'm not going in detail, but yes. But still, we are all going to stuck that balancing act with management of diabetes mellitus, being it type 1 or type 2. So how to improve glucose without causing hypoglycemia? So these are the clinical utility, and this is not the complete list because it is an upgoing. Once we are going to adapt this system, we are going to explore more and more. Yes, there are some limitations that is less useful for patients. So this is not the guarantee. So, which is the best violin? This is not the company of violin. The person who is playing with that and how beautifully he is playing is the important. So with this also, that how we are interpreting the data and how you are using the data for the betterment of euglycemia, this is probably more important. Yes. So from G to 2G, 3G, and 5G. So initially there was professional continuous glucose monitoring, and now with advent of newer insulin pump and these gadgets, so the patient, that is end user, can manipulate his or her sugar with insulin dosing with these systems. And we are going to get the summary of the results, that how in the 24 hours, in the 7 days, in the month, what was the trend. So we are beyond HbA1c. Now we can have that, what is the right going to be? Straight, winding, bumpy, or what we are thinking that if we are using this, that is before meal sugar, we are going to miss all these things. So what is the answer? If permissible, then we should use glucose monitoring. Because if you really want to have HbA1c below 7, we have to be really very meticulous regarding these measurements. And you can see here that this picture is looking perfect. This is a fingerprint and HbA1c was 7.5. So you are thinking that, Abhi, it's okay. Whether it is okay? No. If you are going to see the glycemic variability, it is quite high. This is a very bumpy ride and you don't want that. So this, we have to go beyond A1C. Yes, and this is the reason that if you are going to see this, so it is fairly okay with finger prick method. But this is not okay for the patient. So this is the importance. Yes. Another thing, that there are 2 readings, but we don't have context that how to interpret. So initial, that this was an uprise trend. So you can see here and you can modify the diet and insulin dosing. And the second, the same reading, but what is the trend? Downward trend. And then this is hypoglycemia versus begetting hyperglycemia. So that is the importance of that glucose interpretation level to be seen in context. Yes. So a board with no context, but you are looking, this is a perfect picture. बहुत अच्छा है, बहुत बढ़िया boat है. Now you are having context. So in this, what you are going to see, that this boat is going to sink. If you are having context, that if you are having monitoring over a period of time of glucose trend, not a snapshot, then with a more complete picture, one can prevent potential problems and move away from the danger. So this we want from this presentation. So glucometers only provide a snapshot of glucose status at a given moment with no indication of whether the level is moving upward or downward at a particular rate. Adjusting treatment can involve considerable guesswork. You all agree with that. The sensor glucose trends are more important than absolute measurements. So these are the pathway and why I am talking about that free radical engineering. And these are the free radicals which are going to produce microvascular as well as macrovascular complications. And one second, that is proven. High blood glucose science is confirmed on this point that this is going to produce so many complications. But the second, that is variability in blood glucose, science is highly suggestive on this point. So if we are going to take care of both these points, probably we are going to do justice with our diabetes patients. Yes, so this is the importance of glycemic variation. So glycemic variability may be an important mechanism increasing oxidative stress and vascular complications. Yes, so these are the trends which I am not going to detail, but yes, use of continuous glucose monitoring in clinical practice would provide the required monitoring tool to minimize glycemic variability and superoxide production and may potentially reduce diabetic complication. What we want. So what is the take home? In future, cesium will become must device for diabetics, just like mobile in present day for everyone. Very easy if you start using. Disadvantage, misuse and limitation must be known before we start using. So what is answer? That is, sit together, counseling of the parents and 24/7 mechanism either by you or your team should be there. Calibrated cesium is the best, so you don't have to calibrate. And CareLink system option must be given to all affordable patients. So thank you so much for your patience listening. Yes, this is the most favorite slide. That questions are guaranteed in life. Answers are not always. Thank you so much. Yes, if there are any question or query, or if you want to share something, I know only type 1 diabetes, a bit of type 2, but yes, I'll be happy to answer if there are any query. Thank you.
Any questions from the audience? So it was very nice presentation, sir.
Thank you.
We are moving from glycemic triad to glycemic pentad, considering the importance of glycemic variability and quality life as well. So one question to you.
Yes.
In the present context, which are the patients whom you think CGMS should be recommended in our clinical practice?
Definitely. So there are some patients. One, that is, what is the age group of patient? One, that is adolescent, college going. If you are going to invest our time in teaching a bit about these gizmos, probably he will be the best person to have this. Because one, that I am technically abreast. And one, the thing which was a taboo for type 1 diabetes for his or her friends, now he can easily say that, yes, I am the person who is living with diabetes with a very confident my sugars are like you only. So I do care of myself and I can enjoy with party and other things with you only. So I can play, I can, so one. Second, particularly in a toddler, it is really very difficult that at one point of time, the parents have witnessed for a dangerous hypoglycemia. And I have shown in my picture that trend of the blood sugar So contest of that board, if the parents are aware and the doctor's team is available to take care that how much insulin to be reduced, what was the onboard insulin, so that probably we are going to prevent the dangerous hypoglycemia, or we can take care of hyperglycemia, because there is no fixed diet pattern in type 1 diabetes children 1, and the child should not be restricted that you are having diabetes, you can't have pizza. Yes, of course, he can have pizza. But as a physician or as a doctor, as a team, we should tell them that if he want to have pizza, then how to modify the dose of insulin, and postprandial what you are expecting, and when to top up the insulin. So this is probably we are going to have a fair idea. Thank you.
Thank you, sir. Everywhere these days, the word which is doing waves is alpha, alpha male, alpha female. Now let's hear from Dr. Vinod Mittal ji what alpha cell in our body is going to give information about novel therapeutic target as diabetes management. We welcome you, sir.
So this is a keynote lecture, and there will be no discussions after this.
Very good morning, everyone. It's my proud privilege to be here to share my views on alpha cells as a novel therapeutic target. We always talk of beta cells. Whenever we talk of diabetes, it is always beta cells. We never talk of alpha cells. And alpha cells are equally important as beta cells. So I would be taking you through this journey of alpha cells and there's no conflict of interest here. Basically, we all know beta cells produce insulin, alpha cells produce glucagon. Insulin inhibits glucagon secretion while glucagon stimulates the insulin secretion. So it's little, so there's a paracrine control of alpha and beta to maintain our normal glucose homeostasis. This is what is happening in the body. And alpha cells, the glucagon does not only increase glucose, it is a catabolic hormone. It increases energy expenditure. And it also reduces basically, weight. So when we talk of diabetes, when we know only 26% of type 2 diabetic patients world over on treatment are well controlled, having A1C less than 26. But what to talk of weight? Do we ever talk of weight when we treat diabetes? No. We just try to control only A1C, and we are failing in that. So this is the time, and if we see ADA EASD 2024 guidelines, one of the pillar, A1C is only one part. One of the pillar, the second pillar is the weight management. And the third pillar is cardiovascular risk assessment and reduction. And the fourth is cardio-renal protection. So the four things, day one when we treat diabetes, so it is not only A1C, it is even weight management. So that's what is required today. Simultaneously, most of the patients who are having, type 2 diabetes, they just, keep on gaining weight. So that part has to be addressed as well. Now, glucagon is, again, it's a neglected hormone. It was discovered the next year of insulin. Last year, 23, was the centenary year. But how many people know? We never talk of this. But today, glucagon is the talk of the day. And we have already have GLP-1, we have GIP, we have triple now agonist coming, glucagon receptor agonist. So the future is alpha cell now. Beta cells, we have already failed, giving sulfonylureas and other. So like we should have more and more treatment targeting alpha cells. So primarily, we are already, having GLP-1. Amylin analogs are also being combined with now GLP-1. Then SGLT2 inhibitors and sulfonylureas also affect alpha cells to some extent. We all know that type 2 diabetes, there are two parallel things going on. One is there's a deficiency of insulin and there's a hyperglucogonemia. And there's a paracrine interaction going on. But do we know that, this is through many, chemicals, GABA, exending, PAX4, all these genes are there which have a direct control of alpha on beta. Now, this is very, very important, that from the progenitor cell, it is the alpha cell which comes first and then beta cell. Alpha cell is the guardian of beta cell. This not many of us would be knowing. Alpha cell comes first, then beta cell. So whenever there is a beta cell deficiency, there's an inflammation, there's a glucotoxicity, alpha cells try to protect beta cells. They proliferate in number. So this hyperglucogonemia is in part due to it's a kind of a compensatory mechanism to save beta cells. So alpha cells proliferate to save beta cells, and in turn there's a hyperglucogonemia. And in number also, if we count, alpha cells are a little more than beta cells in the pancreas. So alpha cells are the guardians of beta cell. That is one important. So they try to protect because they contain a chemical which is BCL-XL, which makes them resistant to this inflammation and glucotoxicity and lipotoxicity. So alpha cells are more resistant. That is why they don't fail fast. Beta cells are more sensitive to inflammation. And so not everyone from pre-diabetes goes on to develop diabetes. Not all of them. So in some, this alpha cell proliferation, there is a protection on beta cells and they don't develop. But ultimately, when inflammation continues, even alpha cells fail. And, what remains is hyperglucogonemia and beta cell deficiency or insulin deficiency. So this is what is the end product. But initially, there's a compensatory increase in alpha cells proliferation to protect beta cells. And there's a reprogramming basically going on through alpha cells to beta cell reprogramming. There's a restoration of, beta cell mass in case, if we have some kind of, say gabapentin, not GABA, stimulator. So that can make, and there's certain other agents which can make alpha cells to develop, to go into beta cells. So that is what is the study now going on. Can we do that? And glucagon effects are not only restricted to decrease in appetite, decrease gastric emptying, then increase insulin secretion, energy expenditure. This is the most important, and reduction in body weight, as well as, in fact, now glucagon antagonists have shown to improve resistant congestive heart failure. So overall, there are many, like protein, hypoglycemia, amino acids, they all increase glucagon. Now, how to study this alpha cell? This is another important thing. It's very difficult. Rodent pancreas structure is different from human. So what now the studies are done is the islets, the beta cells and alpha cells from the human beings are injected in the anterior chamber of the rodents. And then there is a formation, more synthesis there. And these alpha cells are then tested by acetylcholine and GABA, other agents. So that's how the studies are, because the structure is totally different. We cannot depend only on animal studies for this. So overall, there is development of now glucagon antagonist to decrease glucose levels. These are under development with the help of glucagon receptor antagonist, antisense oligonucleotides, and spliglomers. Then at the same time, we have agonist. Okay, and then, we have dual and triple agonist, which are already there, which are there in the market. Tirzepatide is already there. Mounjaro in US would be coming soon, maybe in a couple of months to India. And then even triple agonist. It was just, ADA 2023, June 2A trial has been, discussed there, that retatrutide, which is the first glucagon receptor agonist, and GLP-1 and GIP, all three combined. So overall, now the concept is changing, and now the molecule of future for diabetes would be not only GLP-1, it would be GLP-1 with GIP, with glucagon receptor agonist, and then even glucagon antagonist, if there's a need. So antagonists are in fancy stage today, and I've already told that, they are either direct antagonist or there's a neutralizing, aptamers, but they have significant side effects. Obviously, any new molecule, they have to undergo rigorous trials before we put them in the market, commercial market. So Skyrin is the molecule, which might come in a couple of years. Would be the first glucagon antagonist. Because type 2 diabetes patients, they have hyperglucagonemia. So can we give direct antagonist to reduce the levels of that? And these glucagon antagonists have shown effect in basically, like these are the different effects of these. Here, like multiple, mechanism of actions. And this is another molecule, glucagon antagonist, and these molecules have shown to improve heart failure. Heart failure is something which we are failing today. We have 4 pillars of treatment of heart failure, and now 5th, varicose is going to come. And still, I don't know how many, what success we are going to achieve. So glucagon antagonist may be the future molecules. Now, coming to the most important thing is glucagon agonist. And these are the molecules, these are the in thing. And there we have dual agonist GIP. GIP we used to think inert. It's inert molecule. GLP-1 is active. But after bariatric surgery, it was seen that bariatric surgery is not only an anatomical switch, it is a metabolic switch. Means after bariatric surgery, there was increase in GLP-1 and GIP both. And this GIP, which we used to think as inert, is no more inert. It also reduces weight. So tirzepatide is the first dual, GLP-1 and GIP agonist already there in the US market with the brand name Mounjaro. And the same molecule last month, March 8th, it has been approved for obesity. Because today, for obesity alone, only GLP-1 molecules have been approved. Liraglutide. Then we have tirzepatide, this one. The brand name is basically JEP bound. And then semaglutide. Semaglutide, we already know Wegovy as well as Ozempic. So Wegovy is for weight reduction. Then triple is retatrutide, and then tirzepatide as a dual. So this is the most important slide. I would, request you to please focus on this. We talk of bariatric surgery, and a lot of people undergo bariatric surgery. We know a lot of celebrities have undergone. Now we can see here, the bariatric surgery, it leads to 30% weight loss. And it is also not 100%. And lifelong one has to be on calcium supplementation, vitamin supplementations, and the life is miserable. And even bariatric surgery fails. Metabolic adaptation, and they also tend to gain weight later on. This is 30% weight loss. Now, This retatrutide, see this molecule, which was, again is in thing. It is 2A trial only. There, it's a combination of GLP-1, GIP, and glucagon receptor agonist, 24.2% reduction in weight. So instead of surgical bariatric, can we have medical bariatric? Yes, there is a possibility in some patients. See, don't take these are, for everyone. Some patients where these molecules fits in, can we avoid bariatric surgery? Yes, in some people, this is a possibility. Now, then other molecules which are going to be there, carry cagri-sema, which is amylin analog with GLP-1, which is cagrilintide with semaglutide. Then survodutide is GIP with glucagon receptor agonist. Then we have oral, another oral, GLP-1 besides sema will be, or for glipron, 14%. Now, see, this endoscopic balloon and sleeve gastrectomy, the 10th and 11th, just 15%. So that is possible with any GLP-1. So if a patient can afford and can accept, we can avoid surgery in some people, which is, and then molecules have been approved only for obesity, non-diabetic patients. Now, this molecule, retatrutide, the beauty of this trial, this is again very, very important. No non-responders. 100% of the patients responded, means at least there was 5% weight loss in all. Maximum was 24.2% in around 30% of the patients, but 100% of the patients lost some weight, which is not true with any molecule because there are certain non-responders. So in this, at least 5% of weight loss was there in almost all. And these are a couple of new agents going to come up. So future appears to be bright. Alpha cells are equally important. And glucagon has clear-cut two distinct roles. One is obviously reducing appetite, energy expenditure, and antagonist will reduce the glucose levels. So glucagon is already the important target besides insulin. So we should change our focus to more wider perspective. And glucagon, which appears to be, an enemy, is a friend, is a solution, not a problem in times to come. Thank you.
Thank you, sir. It was a brilliant deliberation as usual, and as it is a keynote talk, so we won't have any questions and answers and discussions. Thank you, sir. And now the stage has already been set by Dr. Vinod Mittal, sir. So we will be having twin cretins, tirzepatide, focus on incretins, therapies and new concepts. Dr. Shan Mugwelu will be speaking on that.
I have much pleasure in welcoming Dr. Shanmugh, who is a consultant diabetologist, chairman, academic of RSSD at Tamil Nadu chapter, having served as its secretary from 17 to 21. He is also the regional faculty of the Public Health Foundation of India. He has published articles in various journals and textbook of diabetes, and is honored with the prestigious Professor Dr. Shyamji Moses Oration Award, Economic Times Inspiring Diabetologist of India Award. And to
I think it's enough, sir.
Deliberate on this wonderful topic on twin cretins, over to you, sir.
Respected chairpersons, senior doctors, my doctor friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on twin cretins with a particular focus on incretin therapies and newer concepts. I thank chairperson for the generous introduction. I thank Dr. Faraz for his kind invitations. My disclosures, what I'm going to do for under 15 minutes. The contents of my talk line includes introduction, secretion, metabolism, and functions of GLP-1 and GIP, dual co-agonists, twin cretins, future molecules, and conclusions. Type 2 diabetes is a multi-causal, heterogeneous, progressive cardiorenal metabolic condition, and it is progressive. So multiple intervention will need to be used while managing diabetes as the disease duration advances. Early intensive therapeutic control has proven benefits in clinical outcomes. It's a major risk factor for atherosclerotic cardiovascular disease, heart failure, and CKD. However, CV disease remains the leading cause of morbidity and mortality. So the development of treatment strategies to improve cardiovascular, heart failure, and renal outcomes remains a major priority. So incretin therapy offers an alternative options with modest efficacy, reduced risk of hypo, and a favorable weight change profile. So role of gut in glucose homeostasis. After meal, the gut-derived factors, there is an interaction between gut-derived factors such as endocrine hormones, neural transmission, circulating substrates from the intestinal mucosa, the synthesis of bile acids as well as intestinal microbial composition has resulting effects on glucose homeostasis. In addition to changes in islets, interactions have been identified in the brain, liver, as well as in the adipose tissue. So the intestinal secretion of the pancreas might be stimulated and initiated by a substance of the nature of the hormone or secretin yielded by the duodenal mucosal membrane. Intestinal secretion of insulin, the so-called incretin concept was known from 1906. Secretion, metabolism, and functions of GLP and GIP. So GIP is secreted and released from K cells, namely the proximal part of the intestine, and L cells secrete the GLP-1, and it is acted upon by DPP-4 enzyme. So the intact GIP, GLP amides, they have incretin effect. On the other hand, the DPP-4 processed incretins, they lack incretin effect, namely the insulinotropic property. So the prostaglandin levels are approximately 4-fold higher compared to GLP-1 under normal physiological conditions. So GIP is responsible for of the insulinotropic incretin effect. It has important additional functions that are distinct from GLP-1. Under health in healthy individuals, the GLP, it has insulinotropic, stimulates the pancreatic beta cells to secrete insulin. Glucagonostatic, it suppresses the release of glucagon. On the other hand, GIP is both glucagonotropic, stimulates the glucagon secretion. Insulinotropic stimulates the pancreatic beta cells to secrete insulin in a glycemic dependent manner, dose dependently stimulating the glucagon secretion under hypoglycemic conditions and insulin under hyperglycemic conditions. We have the receptors, GIP as well as GLP. They are present in beta cells, and that GIP expression that is distributed differently in extrapancreatic tissue as well. If you look into the contributions of the gut-derived factors to postprandial plasma insulin secretion, GIP contributes nearly 45%, glucose 26%, and GLP-1 nearly 29%. So in healthy individuals, GIP is the most important incretin, perhaps consistent with the proximal location of the K cells and their immediate dependence on the outflow of carbohydrate from the stomach. Next is the GLP-mediated suppression of glucagon. That is, secreted GLP suppresses glucagon secretion. One is by direct mean or by indirectly. So directly means alpha cells have the GLP-1 receptor. So it acts on the calcium channels. They inhibits the N-type calcium channel, thereby suppresses the glucagon secretion. Indirectly, it stimulates insulin secretion. Secreted insulin suppresses glucagon secretion. That is number one. It also stimulates somatostatin. Secreted somatostatin suppresses the glucagon secretion. So the functions of the GIP and GLP, and very rewarding is central nervous system. It increases satiety, decreases food intake, reduces body weight, and liver improves the insulin sensitivity. On the other hand, GIP, it improves the white adipose tissue insulin sensitivity, reduces the pro-inflammatory immune cell infiltration, and also improves insulin sensitivity in the skeletal muscles. So the effect of GLP and GIP on glucose metabolism in terms of insulin secretion, beta cell mass. So GIP stimulates glucagon secretion, GLP suppresses glucagon secretion. And very important thing is, in patient with the type 2 diabetes, there is a reduced responsiveness of the beta cells to circulating GIP. On the other hand, in patient with the type 2 diabetes, there is reduced release of GLP-1, whereas the sensitivity of the beta cells to GLP-1 is intact. So the incretin effect is diminished in patient with the type 2 diabetes. The incretin hormones account for nearly 50 to 70% of insulin secretion after oral glucose load. This particular study was conducted in patients with the type 2 diabetes. So it is GLP, but not GIP, that increases both early and late stage insulin secretion. Even high rates of GIP infusion had very little effect on insulin secretion in patients with the type 2 diabetes. So C-peptide that is stimulated by infusion of GLP-1 but not GIP in patient with the type 2 diabetes based on the hyperglycemic clamp experiment. GLP restores the glucose-dependent insulin secretion, thereby it reduces glucose as well as by paracrine effect, it suppresses glucagon secretion. Its actions on the heart: reduces inflammation, improves ischemic injury, favors glucose uptake, and improves left ventricular function. On the blood vessels, reduces inflammation, smooth vessel proliferation, platelet aggregation, thereby it improves the endothelial function. On the liver, that is very important. That is non-alcoholic steatohepatitis. That is strongly associated with obesity and type 2 diabetes. GLP induces weight loss, improves insulin sensitivity, decreases de novo lipogenesis, and favors fatty acid oxidation. So we have GLP-1 receptor analog, exentin 4 analogs. We have the exenatide, lixisenatide, as well as exenatide once weekly. Next is GLP-1 analog. We have the lira, dula, semap, both injectable formulation as well as oral formulation. So they are well established with evidence, proven clinical efficacy in reducing A1C, body weight reduction, associated with the low risk of hypoglycemia, and proven cardiovascular benefits. Gastric emptying as well as satiety. GIP increases insulin secretion, glucagon secretion, as well as increases the adipose insulin sensitivity. So this particular slide clearly shows the key target effects as well as the metabolic effects mediated mainly on the white adipose tissue, namely reduces the fat mass, also favors lipolysis. Next is GLP-1 and glucagon. Glucagon increases glucose production, increases satiety, energy expenditure, reduces body weight, improves glycemia, and decreases liver fat. This was highlighted by Dr. Vinod. So this particular slide shows the key target tissues as well as the metabolic effects mediated by GLP-1 as well as glucagon. Next is combining all the three. We have the unimolecular, triagonism, triple agonist. So the effects mediated by GLP-1, glucagon as well as GIP. And this particular slide clearly shows the key target tissues as well as the metabolic effects mediated by each component. So clinically, most relevant mechanism of actions of GLP-1, GIP as well as glucagon with reference to insulin secretion. Next is with reference to body weight as well as lipid profile. So we have the monoagonism, dual agonism, and triple agonism. Monoagonism giving GLP-1 receptor analog alone. That is, we are promoting insulinotropic and anorexigenic effects. Combining GLP-1 with the GIP, in addition to that, we are promoting insulinotropic and insulin sensitizing properties of GIP. Next is thermogenic and lipolytic activities of the glucagon. And when you combine all the three, it becomes triagonism. So what might be an ideal partner for GLP-1 co-agonism? So this was also highlighted by Dr. Vinod. So GLP and estrogen, other hormone combinatorial approaches that also shown benefit in terms of improvement in glycemic control, body weight reduction, as well as with reference to reduced food intake. Next is GLP-1 and thyroxine, also delivered specifically to liver, has been shown to be associated with reduction in the body weight as well as improvement in lipid profile. And GLP-1 and dexamethasone, again favorable impact on glycemic parameters as well as body weight. So the concept of dual agonist, single agonist, unimolecular, monoagonism, dual agonist, unimolecular, dual agonism. Each component, they bind with the receptor and mediate its metabolic action. In patient with type 2 diabetes, there is hyperglycemia. And this hyperglycemia results in downregulation, desensitization, decreased activity of GIP. By putting the patient on combination, GLP improves hyperglycemia. It restores the GIP sensitivity. It causes upregulation, increased activity, improvement in sensitivity, thereby reduce hyperglycemia, as well as it restores both the insulin signaling pathway and other GIP-mediated pathway. So tirzepatide, a novel GIP, GLP-1 dual receptor agonist, has been developed for once weekly administration, comparable to natural GIP, and very important thing is it provides better weight loss and better reduction in food intake, as well as increased energy expenditure. And it is indicated as an adjunct to diet and exercise. We get 2.5, 5, 7.5, 10, as well as 15 milligram. And dual GIP, GLP lowers A1C and weight more than dulaglutide, and improves insulin resistance and beta cell function in terms of improvement in pro-insulin as well as insulin ratio as well as HOMO-IR, and tirzepatide and improve lipid metabolism in that decreases triglycerides ApoB and ApoC in a dose-dependent fashion. And we have the randomized control trial studies. This was conducted to evaluate the efficacy and safety of this particular tirzepatide. So tirzepatide as monotherapy compared to placebo, and this has clearly shown superiority in terms of reduction in A1C as well as body weight. And of course, the overall safety profile was similar. And compared to semaglutide, that is once weekly, and therapy with tirzepatide was associated with a significant reduction in A1C as well as body weight compared to insulin degludec in patients with type 2 diabetes on standard of care. And this therapy has been associated with significant reduction in A1C as well as body weight. Very important thing is the rate of discontinuation were higher among patients treated with tirzepatide. Next is compared to insulin degludec. That is patient with high cardiovascular risk, patient with the CAD, PVD, or patient with heart failure, or patient with CKD has been shown to be associated with reduction in A1C as well as body weight, which were greater compared to patients treated with insulin glargine. Next is on the top of patients with on the top of insulin glargine, compared to placebo, when this particular drug was given, there was significant reduction in A1C as well as body weight. So overall subgroup analysis, this reduced A1C, body weight to a greater extent, and more number of patients achieved the targeted A1C. Reduction in the body weight appeared to be dose dependent with tirzepatide. So future molecules, and again this was highlighted by Professor Dr. Vinod Mittal, that is retatrutide, combination of all the three, GIP, GLP-1 as well as glucagon. Next is we have the non-peptide small GLP-1 receptor agonist, that is danuglipron, shown to improve both glycemic parameters as well as weight reduction. Next is we have the L cell secretagogues, that is the agent that stimulates the enteroendocrine L cells to secrete GLP-1. On the top of it, if you prescribe DPP-4 inhibitor, has been shown to be associated with increased circulating levels of GLP. So in short, reduced incretin effect in patients with the type 2 diabetes is most likely explained. And plasma concentration of the GLP-1 after oral glucose are not sufficient to maintain a normal incretin effect. So well-preserved insulinotropic effect and the glucose lowering potency of GLP in patients with the type 2 may be exploited to pharmacologically lower the plasma glucose concentration. Combining GLP with GIP-R, that is tirzepatide, appears to offer the potential of improved effectiveness compared to selective GLP-1 receptor analog therapy, raising the possibility that it will be an effective treatment for patients with type 2 diabetes. Thank you very much for your kind listening.
Thank you, sir, for a wonderful disposition on twin cretins and especially highlighting GIP, which is often neglected, and the recent advances which you have shown, which are the new molecules coming upline. And thank you for completing well within the time. If there are any questions, sir will be more than happy to.
So it was very comprehensive and lucid presentation, sir. All these weight reducing drugs which are now available in the West, unfortunately, are not available in India.
It will be soon launched by Cipla Lilly.
Saxenda or Wegovy or Zepbound. In the present context, presently, which is the drug which you would advise for patients who are non-diabetic, obese for effective weight loss, with the options available for us today?
Non-diabetic.
Non-diabetic obese patients for significant weight loss presently.
Very limited, sir. No.
Would you advise any off-label GLP-1?
No. So we can talk only guideline recommendations, but not offline.
Wegovy has been cleared by the DGCI.
Yes.
So Wegovy will be available in the next near future, I think.
Yes, sir.
Already been cleared. So
Thank you, sir, for a wonderful talk, and we close the session. Thank you. Thank you for having us here. Thank you.
The ceremonial lighting of the lamp marks the commencement of our event with a symbol of illumination, wisdom, and auspicious beginnings. I would like to call upon Dr. J.B. Farishta, Chairman of FDARS, Dr. Shaishta, President of FDARS, Dr. Kali Prasad Rao Garu, IMA President. He could not join the session due to personal emergency. I would like to call upon Dr. TV Srinivas Garu, Dr. Dayal Singh Garu, Dr. Minhaj Nazirabad Garu, Dr. Vijay Vishwanath Garu is the President-elect of RSSDI, Dr. C.H. Vasant Kumar Garu, Dr. Abdul Hamid Zargar Garu, Dr. P. Raghuramlu Garu, who is the Vice Chairman of Virinchi Hospitals, Dr. Satyavedulu Garu, Dr. Bhaskar Chari, who is the Director of NIN.
ఇప్పుడు అది అవసరం లేదు కదా ఇది Everyone to please give a big round of applause.
शुभं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदः
One minute. I'd like to, please hold on, members. We are going to introduce the SD times. Inauguration of this. Delegates, please be on the stage. A big round of applause for HD Times. HD Times, it's a quarterly magazine. It is published pan-India. Okay. A big round of applause for HD Times. Thank you. Now I would like to request, delegates, you can please leave. Thank you. Now I would like to request all the chairpersons and the speakers of latest updates in medicine, please gather at selfie booth. Your felicitation program will be held over there. Thank you. You start.
We commence this wonderful program with an inspiring quote by Dr. APJ Abdul Kalam. Excellence is a continuous process, not an accident. So, ladies and gentlemen, it's with great honor and enthusiasm that we introduce Professor Abdul Hamid Zagar, who is MD/DM Endocrinology from the Center for Diabetes and Endocrine Care. Professor Zagar will be addressing on the compelling topic of non-communicable disease some new insights. We welcome you onto the stage, sir.
It's not moving here. Can you?
With you just now. Good morning, friends. It's a wonderful occasion for all of us to be here. Thanks to Dr. Faraz and the team. And it's so thoughtful of the team that they have chosen one of the greatest endocrinologists of our country who came all the way from Kashmir, and that to speak on a topic dedicated to one of the greatest sons of India, our soil, Sri late Abdul Kalam. So I thank Dr. Asgar very much for being with us, and we are looking forward to listen to him. Thank you, everyone.
I take this opportunity as I am a Hyderabad City Branch Secretary. I take this opportunity to congratulate Dr. Faraz, and I would also like to announce NatCon. NatCon has been given to Hyderabad City after many years. It will be there on 27th and 28th of December. So please block your dates for NatCon, that is the annual conference of IMA. It will be held in Hyderabad. Thank you.
A very good day. It's neither good morning nor good afternoon. We are bang on dot there. Dr. Vasant Kumar Faraz, members of Frontier Diabetes Organization. I feel honored and humbled to be associated with Dr. Kalam. I had the honor of spending a day with Abul Kalam a couple of decades back in Aurangabad in a biological park. And it was so amazing discussing things with him. And you know what he said? If you guys don't ask the questions, I will start asking you. And I might expose your weaknesses as physicians and clinicians. So you better start asking me questions. And I asked him, I said, sir, what are your thoughts on brain drain in the country? He said, Doc, what brain drain are you talking about? The quality and the quantum of manpower we create, even 10% of that does not go out of country. The problem is not they go out of country. The problem is, do we appropriately use rest of the 90% in this nation? Huh? And that's what I think is our problem. And what we discussed on that day would take another day. Everybody knows about Kalam. I'm nobody to. What I'm going to talk in the next 20-25 minutes is probably what I have seen happening in front of me as an endocrinologist in the last 4 decades. When I was in the medical school, we didn't have a single thick or obese individual. Even in the medical school, we used to play cricket and gulli danda, I don't know what they call it on the southern hemisphere. But today, look at the children. It's not only what is happening to the epidemiology of the disease, Vijay. It is what is happening to the total mankind. The basic architecture of the mankind is changing. And that's what I'm going to talk to you about today. Just look at this. This is United States. And this tells you about the concept of obesity in the United States in 2000. Why I chose this slide? Because in mid-60s, authorities, healthcare professionals, and the government of the United States realized that coronary artery disease is increasing, obesity is increasing, and they first started a program known as cholesterol education program, I think in 1966 or 65. And it was that program that ultimately became ATP1, ATP2, ATP3. How do we take care of coronary artery disease? The point is, if you look from this point of view, time frame, 40 years earlier, in that nation, people had become aware that obesity was an issue. Coronary artery disease was an issue. Right? And at that time, and a decade after that, during our medical education, we were taught that people in the Indian subcontinent are genetically immune to ischemic heart disease because the word coronary artery disease was not known. And there was a chapter on that on a famous trilogue book by no less a person than M.M. Ahuja. And this is what was in the United States. And just look, just half a decade later, after that half a decades of education to a population which has the highest tools of education, comprehension, understanding, and real world happenings. Look at what is happening to obesity. Just in this half a decade, it has escalated, almost doubled up. This only tells me that human beings have a very little potential of understanding about themselves and understanding about their health care. This only tells me that eating is an addiction. This only tells me that once you get addicted to whatever form you eat, in your younger days, this becomes sacrosanct. This not only primes your taste receptors, but it also primes the requisite centers in the brain. Then you are a victim. That's why you need those. Vinod was telling me about GLP-1s, triple combinations. I was telling Vinod the first time I heard about glucagon was by no less a person than Roger Unger himself. And low below wire in Srinagar. I was an intern in 1976. And that time he said, it'll take quite a while for people to understand the relevance of this glucagon. And it's taking quite a while to people understand in the subcontinent what is happening to us. This was one of the first papers 2.5 decades back we published when we first time started realizing in 80s. Now certainly you know, those youngsters, 18, 20, coming with polycystic ovarian syndrome, randomly do a blood sugar 156. Many times, you know, we say some problem with the machine. These glucometers are not well sensitized or not that accurate. But then we started realizing that yes, obesity is coming in and it has started coming in. And we found out it was much worse in women than in men. Initially, my personal thought was that probably it was more in women than in men in the, at least in the valley, because probably women were more homebound and they were not moving out like men. But when I looked at the real time happening, women were physically doing twice the work than men in whole of